Welcome to everyone who's listening. My name is Jagdeep Singh, Head of Clinical Proposition at New Medica, and I'm also a community and hospital optometrist. In today's podcast, we'll be discussing the importance of lens quality, why intraocular lenses matter to patients and referrers, and the role of optometrists in supporting patients to make the right choice for their needs. Now, today I'm joined by two very special guests. The first is Sai Kohli, and Sai is a consultant ophthalmologist surgeon at the QE in Birmingham and a consultant ophthalmologist and partner at New Medica Birmingham. He's been qualified for many years and completed 3 years of academic research in the field of corneal stem biology, culminating in a PhD in 2009. He also completed his initial specialist training at the world-renowned Moorfields Eye Hospital in London. He's one of the few to be a fellowship, trained in multiple specialties, including cornea and external eye disease, as well as cataract and refractive surgery. Our second guest is Mukesh Sodha. Mukesh is a director and optometrist at Sodha Opticians, an independent practice based in Birmingham. Mukesh has been qualified for over 40 years and has a wealth of experience. So let's get straight into the conversation. Sai, why is lens choice so important when it comes to cataract surgery?
Lens choice is crucial because different patients have different needs. Not all patients are the same. They do different jobs, have different hobbies and interests, and also not all eyes are the same. So it's vital that we provide time to assess these patients accurately so that we can give them the appropriate lens option. As probably most of the listeners know, there are many, many options in the type of lens that we use. By far the most common lens that we use at New Medica are high quality monofocal lens implants. We use those in all our NHS patients. It does a brilliant job. It gives excellent vision at a particular distance. So in the majority of patients, they choose to have good distance vision. So we can ensure that most patients are almost spectacle free for distance activities such as driving, watching TV, walking around. However, they would need spectacle correction for intermediate and near vision. Also, monofocal lenses don't correct astigmatism either, so one would need a toric lens for those patients. So to be clear, the vast majority of the patients that we see at New Medica will choose to have a monofocal lens implant, and they do very well with those. However, if they want to, there are options for those who wish through either paying privately or through their private medical insurance to have these premium lenses, i.e., those that correct for astigmatism and those that allow greater spectacle-free vision as well.
I think it's so important, given the breadth of options when it comes to intraocular lenses, that patients are aware of the different ways that they can correct their vision after cataract surgery, isn't it? How do you identify which type of intraocular lens is most suitable for a patient then?
So I think the most important thing that we do is we provide adequate time to speak to the patients. Where people go wrong, I have the role in my NHS job of often dealing with patients who are less than happy with lens options that they've had in various practices around the region. And so at New Medica, we pride ourselves in getting this correct. So it's basically to provide personalized care. Now, inevitably, that will involve a longer chair time. So we provide longer times to spend with the patient. It's not, 5 minutes, done and dusted, decide on lens. It's helped a lot by the fact that we know more about their personalized options by a lifestyle questionnaire. So all patients who are referred to us will get detailed information about cataract surgery, but also a lifestyle questionnaire. So before a patient is brought in to see me, when they come and see me in clinic, I've had a look through that lifestyle questionnaire, and that allows me to know what their requirements are. So the choice they have is always informed. Whenever I see patients in my NHS practice who are unhappy with lens options, it's nearly always because they didn't really understand about the lens being put in, and we don't want to have that happening at New Medica, which is why we use the lifestyle questionnaire and the additional chair time.
Yeah, I think the two words that you used that sort of really stuck out for me there were time and information. So giving patients that time to just
Yeah.
understand their needs and the information so that they can make an informed choice is absolutely critical. Mukesh, do you think there's a role for community optometrists in helping patients to understand the importance of lens choice based on what we've just talked about?
Yeah, most definitely. One of the my practice is based in the inner city, and my client base is by and large very poor, and so they're going to opt for what's available through the NHS. But I need to be mindful that I do get patients who want uh, their vision corrected for both distance, reading, and so they do ask. So yes, I'm aware, but not to a great deal. I mean, my knowledge would stem to saying whether you want multifocal lenses or clear single vision lenses, and that's it. That's it.
Si, can you tell us a little bit about the intraocular lens that New Medica uses that you touched on earlier and what makes it unique and how it benefits cataract surgery?
So for us, it was really crucial to have the best monofocal lens implant. Um, all the partners working at New Medica, in all New Medicas, but certainly in Birmingham, are highly experienced. We've done, 10,000 or more cataracts. And so we know the advantages and disadvantages of various lenses. I think that the crucial uh, part of the decision making was to use the lens which gives really high quality vision, but also has the lowest risk of producing posterior capsular opacification. So, as most of the listeners will know, that after cataract surgery, a small number of patients do develop some scar tissue across the back of the lens, and this requires subsequent treatment in the form of YAG laser capsulotomy. Now, what people may not know, certainly ophthalmologists are aware, but what optometrists may not know is that there's a huge variability in the percentage of patients having posterior capsular thickening dependent on the lens type. So let's just assume that the cataract surgery was done in a uniform way. The lens that we use has the lowest rate of posterior capsular thickening by a long way. So it's quite nice in that we have independent data. The Royal College of Ophthalmologists provide us with the National Ophthalmology Data Set, the NOD data, which shows that the chance of requiring YAG laser with our monofocal high quality hydrophobic acrylic lens is tiny. It's between 2 and 3% at 3 years. Now, most optometrists will know as well that if they look at their patient population, that that doesn't seem to add up. If they look at how many people are undergoing YAG laser, so certainly I can speak for Birmingham in that the provider that is performing the majority of cataracts in our region has uses lenses which have a posterior capsular thickening rate of multiple times that. In fact, if you look at the 5-year data for these lenses being implanted, there's approaching a 50% chance of requiring YAG laser capsulotomy. That is absolutely huge. Um, and I think certainly from an ethical standpoint, I think it's important for us to use a lens which minimizes the risk of requiring YAG laser capsulotomy. There's two reasons for this. YAG laser is an extremely effective treatment, does very well at clearing up the scarring and gives good vision. However, it does have the small risk of complications. If you're doing literally thousands and thousands of extra YAG lasers in any particular region because of the lens you're using, that will cause increased patient harm. Secondly, it costs a huge amount for the NHS as well because these patients then need to come back to have further treatment.
If I can come in, I always assumed that posterior capsular thickening was just the norm, and I wasn't aware that there are lenses that have a lower rate of PCO.
we work very closely with optometrists, and so when I've spoken to them about this issue about different types of lenses with different uh, chances or percentages of people developing posterior capsular thickening, it the reaction is exactly as you said. They always assume that most lenses are the same, and some produce posterior capsular thickening in patients, maybe related to the patient or the surgery, and weren't aware that it's absolutely related to the type of lens that we put in. Now, the cynic would think that, well, let's just put in the cheapest lens and hope for the best. That will save the provider money. And I think that if all of them produce the same quality of vision and the same level of posterior capsular thickening, possibly that's a reasonable thing to do. However, I've just discussed the fact that there is a multiple increased fold of posterior capsular thickening. So I think personally, we've taken the decision at New Medica is to use a really high quality, expensive lens because it provides much better outcomes.
I think we've touched on a really important point here. Mukesh, can I bring you back in? What would your advice be to optometrists when it comes to discussing intraocular lens choice with patients? Because there's as you and Sai have both said, there's some clear differences between the different types of lens choices, even if it's a standard monofocal lens that we're talking about NHS patients. What would your advice to be optometrists when it comes to sort of discussing those lens options with patients?
With patients, I mean, obviously, I'm very concerned that I don't want to start discussing an after cataract with a patient when they've got so much more to think about. As soon as you mention the word cataract, again, with my patient base, there may be a period of 2 or 3 months where they settle, they worry about this. So I have to train my patients to understand what they're going to go through is going to be something not as traumatic an experience. It's not a major surgery. It's going to be in an ambulatory setting. They're not going to be hospitalized. They're not going to be in bed for 3 days. So all that coaching. And to add to that I have to tell them after having the cataract operation, they might have to have further surgery in a year's time or 2 years. That's what I would really hope to want to reduce. And again, it's inconvenient for the patient to have to come back and back.
Absolutely. So, Si, can you explain to us why New Medica chooses to use this higher quality lens that reduces posterior capsular pacification compared to others?
Certainly. I mean, I think the simple answer is it's the best thing for the patient. As we've said, as Mukesh has quite eloquently said, patients have a lot to think about. They remember very little of what's said. It's enough to know that they've got a cataract which requires surgery. To then tell them that actually, depending on the type of lens used, you're likely to then need to come back again. And that can be quite frustrating for the optometrist because when this happens in a very short period of time, they've literally had their surgery, had their new glasses prescribed, and within months they think there's something going on with the glasses because the vision's gone down. And in fact, it's because some of these lenses are associated with fairly rapid posterior capsular thickening. But most importantly, it saves the NHS a huge amount of money. I mean, I'm really proud of the fact that, when I was being considered to be one of the consultants at one of the New Medicas, we were provided with the data of how much money that we are saving the NHS by using these high quality lenses. Those high quality lenses cost New Medica more money, but in fact, by putting them in, they have saved the NHS several £1 million in the short period of time that we've been open. I think New Medica is relatively still at the start of its journey, and we know that if we look in the next 5 or 6 years, we'll have probably saved approaching £20 million by using those lenses through preventing unnecessary YAG laser capsulotomies.
I think the ethical points and the cost saving to the NHS are absolutely key. Mukesh, I'd like to bring you back in again. How do you think cataract surgery providers can work more closely with community optometrists to ensure a smoother cataract journey for patients? You've got loads of experience. I'd be really keen to get your views on this.
I think the personal and direct contact with named professionals is really important. For me, I'm fortunate that New Medica is nearby. I've been to their meetings and I've talked to the consultants, and I am comfortable that, if I have a patient problem, that I can pick up the phone and ring them up, and there is a process that we can go directly to discussing that, rather than having to write letters, and which apparently will go in the dark, and we don't know if they've been read or actioned upon. So that's that. If I could come on the last point again, if I can draw a parallel about what happens when you choose a lower quality product to provide to a patient. Now, the NHS is already burdened with an ever-increasing number of patients because of the aging population. We got ophthalmologists who are probably overworked in clinics, and now they're taking an increasing workload. Now, if they were to provide a lower quality lens, then what's going to happen to their chair time? This happens to me in practice. I know from, let's say, if I draw a parallel to progressive lenses or spectacle lenses, if you provide a lower quality lens, inevitably the patients are going to come back with dissatisfied, and they're going to increase my own chair time. So my own personal throughput is way reduced, and more frustrating for me. And they could say the satisfaction's less once I know that my patients have been really happy, and they go away for 2 or 3 years, whatever. They are singing praises for me, so I can see more patients and different patients.
And just to bring you back in again, Si, so what are your thoughts on how optometrists, community optometrists, can work more closely with cataract surgery providers to ensuring a smoother journey for patients?
I think that the unique thing about New Medica is that our hospitals are actually owned and led by consultant ophthalmologists. So we're the ones who are actually caring for the patients. We know many of the optometrists through the fact that most of us are very senior consultants. So, I work with, I've been an ophthalmologist for over 20 years and been a consultant for 12 years. My colleagues similarly have been consultants for a very long time. And so we are all very focused on ensuring that our patients have the best quality care. We know how to provide it. It's lucky in that we are able to have a say in the staff that are working here, the way that even that our hospital looks. We had a lot of say in deciding, what instruments we have, how the hospital is laid out. But I think and that is unique in that you are being looked after by the consultants that you are referring to. Okay. And unfortunately, that's not the case in many providers. You don't know who you're going to see or who's looking after the patients. The other thing which is unique to New Medica as independent treatment sector is that we are able to offer a wide range of treatments. So certainly in our unit, not only do we look after cataract patients, YAG patients, we also look after patients with macular degeneration, with glaucoma, and many other conditions. The number of those conditions that we are able to provide for in the NHS is dictated by the ICB, and we are currently in talks in Birmingham, for example, to have a full spectrum. So we are able to see any patients that that optometrists would like to refer to us, because we are aware that there's a huge problem, not just in cataracts and YAGs, but in, for example, glaucoma, in general ophthalmology, etc. So we look forward to providing a sort of universal ophthalmic care package for our optometrists to send their patients to, because I think that that's what's needed in ensuring long-term success of the ophthalmic optometry partnership. I mean, optometrists are really integral to the work that we do here at New Medica. And as Mukesh has said, not only do we have direct, so when they pick up the phone, if Mukesh wants to talk to me, for example, he will ring up and say, "Can I speak to Professor Colley?" Or there is a consultant on site every day. So you know that you are going to be speaking to a consultant clinician, whatever the problem. When we are on call in the evening, when a patient has a problem, that call comes through to one of us in the evenings, not to any of the other members of staff, but to one of the consultants. So it means that worries, concerns are dealt with rapidly. So it means that, patients typically, calling someone, maybe speaking to a member of admin staff, will then get put through to a nurse and then put through to a doctor. It can be quite a frustrating and stressful experience. And similarly, it'd be interesting, Mukesh, to get your thoughts on how easy it is to get access to the different independent providers. For example, say if you wanted to get access to a doctor at any of these other sites, how easy is it? Because we pride ourselves on the fact that you can just drop us a line, you can drop us a text, get on the phone. Are we providing that service?
I think so, and that for me is been a key defining, differentiating thing with the other providers. I wasn't aware that you could actually, patients could actually ring up after hours, and then you'd be answering the calls yourselves. So that makes a big difference. I know that I've left messages for other providers to ring me back, and they've not been answered back, and I've had to resort to writing letters or emails, and I'm even not sure if they're being read. So they don't get a.
Yeah, I think that's really crucial, because I think people forget at the end of each of those inquiries is a patient who's often really, really anxious and stressed. And the nice thing about being able to speak to a senior clinician is that those can be resolved. In the vast majority, it is just a bit of reassurance, but in the very rare occasion that there's something more serious, it means that the patient can be brought in straight away and seen that day, which is something which I think is unique to New Medica.
Absolutely. Yeah, I think the points yourself and Mukesh have covered are absolutely key. Sai, Mukesh, thank you so much for your time, and thank you to everyone for listening. If you have any questions, please feel free to contact your local New Medica clinic.
Thank you very much.
Thank you.